We're going to take a look at public engagement from a little bit of a different perspective. The impact on engagement for specific group patients in the healthcare system. And so I'd like to invite Willow Brocke to come down, and who's the Director of Patient Engagement for Alberta Health Services, to present. Thank you.
My grandfather used to say you can learn anything you need to know in life from a tree. And I really think that's particularly true for what I'm fascinated about, which is really about the intersection between knowledge translation, engagement, and making awesomeness happen in organizations and in communities. And I don't know if you've ever read the Awesomeness Manifesto out of the Harvard Business Review, but it's a beautiful manifesto to read about the difference between just doing good things and making something really awesome happen. Awesomeness has to do with love. It has to do with creating really thick value and with leaving people genuinely better off than they were before, not just with bells and whistles that they didn't really need. So before I start, I just say, oops, it's music. Try that way? Okay. Just a warning. I was born in California in the 60s. Teenage parents. That's how you get a name like Willow. So I grew up at a time where humanistic ideas and innovation was abounding in the state of California at that time. And I ended up in my education taking a very meandering course through about 11 years in the arts, through the fine arts, through art and music and jazz studies and drama and dance. Finally figured out I needed to feed my kids, so I finished off with a degree in social work with an emphasis in community development and policy, and eventually went on to do a master's degree in educational psychology, which is the psychology of how people change through learning, which is what I'm really fascinated with. And I ended up spending most of my time working in organizations around organizational change and using engagement as a tool to build capacity in organizations. So, but my real story started when I was about 7. Now I'm not getting anything. There we go, okay. We moved a lot when I was a kid. I don't know if any of you had that experience of moving a lot, but it meant that I needed to learn how to engage really well, really young, because I was always starting again in a new community. And when I was about 7, we moved to a Northern California community where I had to figure out how to make friends, and it was July. It's really hard to make friends in July. School's still ways off, and it was lonely. So I would love to read Archie comic books. And in Archie comic books that month, there was an offer that you could buy a kit to make a circus in your neighborhood with all the kids. It was the perfect solution to what I needed. So I saved up my dishwashing money, ordered the kit, waited for it to come in the snail mail with great anticipation. And when I finally did get it, I put all the cardboard cutouts together and read all the instructions and waited on my front lawn for the kids to come, which of course they didn't. So by the end of the day, I was there alone with all of my awesome ideas and still no friends. So what I learned from that experience is that I really don't like it when no one RSVPs to my let's do this amazing thing invitation. But the other thing I learned was this: be relevant to the people you want to reach. And I'd say that that sentence right there has really guided my career hugely in terms of engagement. It's a simple idea, but it's also a really important idea. So what happens when you don't know how to do this? Kind of like what happened to me with the circus. In Canada, well, actually, let's go back and look at the definition. Relevant, having significant and demonstrable bearing on the matter at hand, which is why you're all probably about less than a foot away from your smartphones right now. Okay? Significant and demonstrable bearing on the matter at hand. Really, really important. If you don't know how to do this, you end up with this problem. In Canada, this is the problem. And I don't know about you, but I end up at dozens and dozens of meetings all the time where we have amazing plans and we keep going right up to the precipice of actual implementation, and we get scared and we back up. Or we think, how can we force this? Or how can we drop it in like a parachuted food package that everybody's going to rush over and grab? It just doesn't work. This fellow who wrote The Innovator's Prescription, or The Solution for Healthcare in America, goes so far as to say this: people will actually only adopt innovation that helps them do what they're already trying to do, period. Again, your smartphone. You'll pay zillions of dollars for these things because they actually help you do what you're already trying to do. Really, really important. So how do you find out, though, what people are already trying to do? Our big mistake often is that we make assumptions about what it is that they're trying to do. Well, this is the such and such department, so obviously we know what they're trying to do. But we don't necessarily know. And this woman, Annette Simons, I actually talked to her on the phone not that long ago. She's a really, really brilliant woman. She's a consultant for NASA, for IBM, for the U.S. Armed Forces. And what she says, I think, is very, very important. We talk about this a lot lately, the power of stories. Civilizations rise and fall on their stories. If you want to change a culture, you have to go in and understand the current story, and then you have to bring in a new story in a way that makes sense to the people who are there. There is no other way to change culture, period. That's it. The problem is that we tend to come in and bring the new story in without understanding the existing story. Okay, we forget about listening, and that's kind of why I called the presentation the listening tree, and we'll come back to that in a minute. So I want to tell you, with a story, I like this picture because a story is a portal between one world and another, between one paradigm and another, between one way of being and another. So when we come in with our story and we don't actually understand the one we're engaging with, it's a big problem. So I want to give you an example of some work that I did in health recently that showed how doing this well can make you very successful in terms of making awesomeness happen. So this is a story from school-based mental health. In the job before this one that I had, I was in charge of school-based mental health or student health partnership services for the Calgary area. So that's about 350 schools in the Calgary zone, all the different school boards. And I had 15 therapists. And the model for the service was take the child out of the classroom who's having mental health issues or behavior problems, fix them please, and put them back. Why? Because the teachers were overwhelmed. They were overwhelmed. They had 35, 40 kids in a class, about half of them with behavior problems, trauma, immigrants from other countries where they'd been in war zones. The teachers were completely overwhelmed. So they needed these kids fixed and brought back in a way that they could be taught because they had ants in their pants and they were poking each other and they were really, really stressed, the kids were. Not a very great model though, since one therapist can only serve about 30 kids a year. And I couldn't get anybody to listen to me about a different kind of a model because that was the way the funding was supposed to go. The funding said, master's level therapists, fix the kid, take them out. I knew that the patterns in our data meant that we needed to work with the teachers differently. We needed to give the teachers the information and the skills they needed to work differently with those children that were being referred and the other 10 that they couldn't refer because there wasn't enough resources for us to treat them. Okay? But there was no popularity for that. Imagine going into a classroom where teachers are completely overwhelmed, much like our nurses are on the front lines, and saying, okay, we're going to give you the tools to do the mental health work with the kids. No, not a very popular idea at all. No way were they going to do that. So I waited until they were going to shut down the service in our highest needs area, because guess what, it wasn't working. And I used that moment for a disruptive innovation. I don't know if any of you are aware of the term disruptive innovation, but it's what you can do when nobody cares anymore about that particular thing, and you can go in and try something new. So what we did was we had all the information that we needed to share with the teachers, but we needed to find a way to understand them, to connect. So we went in listening first. We asked them, what have you tried with little Johnny? What worked well? What happened when you tried it? What else do you worry about? Tell us about the other children in the classroom that are exhibiting similar behaviors to Johnny. What's happening with them? And we fed it back to them and made sure we got it right. What was the story? We listened to their tears because they were very, very frustrated and very overwhelmed. And we let ourselves be changed by that listening. And that's a really important part. We let ourselves be changed by it. And then we said to them, you know what? What you've told us is really important. We're going to go away. I'm going to go away, and I'm going to come back in a week with some ideas for you. When we came back in a week, they were all ears. They were totally ready to listen to what we had to do because they felt understood, they felt engaged. It wasn't a token thing that we were listening. We were truly listening to them. And then they were able to not only absorb that information, but to apply it to the other children. And what we decided to do was measure the result. So I want to talk a little bit about what happened next. So in the end of the project, this is what we were actually able to achieve. I'm going to tell you how we did it. That's 90% without a single extra penny of money, okay? So what did we do? This is how we measured. This is called the problem severity rating scale. So the teachers rated the child based on information on each of these levels to how difficult is this child to teach? What are the behaviors I'm seeing? How bad is it? Okay? And in their perception. And not just the kid that was referred, but the kids who were not referred, the other children that were in their classroom as well. And then we coached them. We gave them our cell phone numbers, we coached them. They applied their new skills to all of the kids that were suffering. My first pilot, I was able to use one half-time therapist in that high needs area where they were going to shut it down. And this is what happened. She was half-time. So that first blue bar, normally in one school year, she would have been able to treat 15 children. Okay? As a result of the new way, she was actually able to work with the teacher in a way where 84 other children who wouldn't have received services, their needs were actually also addressed by the changes. 45 of those children had improved problem severity ratings, and 56, because we're talking about a high needs area now, were connected to other services. Those other 56 would never have gotten services if we hadn't worked in this way. We wouldn't even have known that they were there. Okay? So it went so well, and we got such good data that the next year, the next semester, the school board let me try it with 7 therapists in 7 schools. So this time we were able to treat 210 kids, 188 that we wouldn't have been able to treat otherwise, 135 improved their ratings, and 64 only were connected to other services. Now remember, now we're not just in a high needs area anymore, now we're in the whole city, right? Okay. Here's what happened with the problem severity ratings. So we went from an average of down here up to here, across the board. Here it is with the kids who were referred on the green line. They started out much worse in the difficulties, and the kids with the blue line were not referred to other services. They were treated just with the way we worked with the teacher. Okay, here it is broken down by school. Okay, and here's the analysis. So the problem severity change was significant. It was a big difference for the teachers. The teachers were amazingly less stressed by the way they could interact with the children. The referral, whether or not the kids were referred, were significant. What wasn't significant was what year it was, what therapist it was, what school quadrant. None of that mattered. What mattered was that the method worked. So what happened next? Every school board in the Calgary and surrounding area adopted the model the following year. Bang. Every school board. So that's the Catholic, the Rocky View, everybody. Increased capacity exceeded 90% for the project the following year, with results still holding steady 4 years later. So right now, we're still at 90% increased capacity by working in this way. There was an award that was given from the Alberta Mental Health Showcase for practice innovation. We accepted invitations to present the work in several countries. And the success of the work meant that Dr. Sam Chang decided to use the model that we were using to address the shortage of psychiatrists in Canada. We have about 400 child and adolescent psychiatrists in Canada, and we need about 4,000 to meet the need. So what they're doing is teaching GPs in their offices how to do mental health assessments for kids in their offices, so kids don't wait 2 years for mental health assessments. So that's pretty cool. If we had gone in saying to teachers, this is what we want you to do and this is how we want you to do it, never would have worked. So it's that engagement being the active ingredient in engagement, right? It's starting by listening that was the trick. Okay. So that's always the question, right? Big deal. You did it once, whatever. Can you do it again? So the next project that I took on isn't the role that I'm in now. And right now we're partway through looking at what is possible and how we're working. So here was the situation when I started 2 years ago as the director. We had these 5 zones in Alberta Health Services that had just been formed and come together. Here was the situation. We had 100,000 poorly engaged employees. At that point, we had a real spanking in terms of we're not engaging very well with our staff. About 7,000 contracted physicians, 3.5 million Albertans across the 5 zones. New governance structures that were shifting weekly and are still shifting. So nobody knew who to call to order paper clips. It was a little bit of pandemonium at first. It's better now, but the mandate we got was this: make us the best public funded health system in Canada by including the patient and family perspective at all levels. Okay? And this is the funny part. Here's your 6 staff, 2 with relevant experience. Okay? This has never been done before on this scale in the history of the world. So good luck. And many of you who work in large organizations know they never tell you this, but it's true. You probably have less than 2 years to make a significant impact, or you'll be reorged. You'll be swallowed up and turned into something else. It's about 18 months to 2 years. You better become famous for something, or you're moving on. Okay. So we had to get really clear. I want to focus for a minute on why. Why patient engagement? Why does it matter that we look at what we're doing in Alberta Health Services through the patient's eyes? And I know I'm speaking to the converted here, but I wanted to break it down to its most simple message. And it's basically this. What we learned was that, according to the Institute for Patient and Family-Centered Care, patients and families need 4 things. They need this: please respect me, please listen to me, please involve me, and please don't confuse me. Okay, that's it. Pretty much every complaint of the 9,000 complaints we got last year, the biggest grouping is all about when we screw up on this. Okay, it's not so much about wait times, a little bit, but it's mostly about how we communicate. According to the Institute for Health Improvement, when do they need these 4 things most? When we say hello, at moments of great vulnerability, and when we say goodbye. That's it. If we can do those 4 things at these 3 moments, suddenly we've transformed the health system. Okay? What happens when we do those 4 things at those moments, according to the international literature, is this. We get improved patient outcomes, improved safety, reduced wait times, reduced costs, improved teamwork, and improved care provider job satisfaction. Really cool. Turns out when we build the humanistic environments our patients want, works really well for our staff. They want to work in those environments. So that gave us our North Star. So no matter what we do, everything we're doing is aiming at bringing that patient and family perspective to every level of care, from planning table right down to the front lines, so bringing patients on board. So we started to get ourselves organized. We started doing a ton of research on leading practices around the world. What are the exemplar organizations doing? We got ourselves a patient advisory group at the highest level of the organization, which is about 20 citizens who meet every 6 weeks to advise us and advise us on our work in all different levels. We built materials that were our best guess about what was going to help us change culture on the front line. And I say guess because we haven't listened yet, right? It's our best guess. We have a lot of clinicians on my team that have a lot of history with being on the front line. So our best guess, we tried to make them easy to gulp. And I have one of my educators here who knows what I'm talking about. If you are a nurse who's operating at 110% capacity all the time, and I'm going to bring you information, it better be easy to gulp. We have to get it there quick. So we had some really innovative ways that we're doing that on our website and with the tools that we're building for them. But everything that we bring them is based in research, and it's based on evidence from around the world. And if I had more time, I'd tell you more about what we built. But then we had this great bank of knowledge, just like my therapists and the Student Health Partnership did, but how are we going to implement? How are we going to actually look over the edge of that precipice and engage with them, with the staff, in a way that was going to do this? Because guess what? People in healthcare, we love control. I'm a healthcare provider. I spent 20 years in mental health providing services. We love to take care of you. Okay? But we don't really want to see you come look behind the wizard curtain. Okay? It makes us anxious. That really I'm just a kind of a pretty educated person taking my best guess every moment on what you need. So that makes me a little nervous when you come and see the little man behind the curtain. So there's a lot of anxiety in healthcare when you start talking about bringing patients to the planning table, really bringing them to the planning table right at the beginning. Lots of anxiety. So we had this anxiety we had to work with. So we knew that. We weren't just going to come and give them tools and have them pick it up. We needed to start by listening, by really listening. So here's some of the questions that we asked. I love this. This is Story of Water by a group of Ethiopian children. It really speaks to that whole idea of how we see things from the inside. So here's some of the questions we ask when we go in listening. Okay, what's the most important thing you do here? I don't know. What are you most proud of and what do you worry about? Okay, that helps us get at what's the culture? What are people thinking about? What do they think is important? Really listening to that. When you try to deliver patient and family-centered care, what gets in your way? Okay, and I asked them, what would a video camera see? Okay? Because if I say what gets in your way and you say, well, my manager, she's real, doesn't support us. Okay, well, what would a video camera see her doing that shows you that she doesn't support you? Okay, so it gets at the objective, what we can see objectively. When you are able to successfully provide care in a patient-centered way, what specifically is happening that's making that possible? So now we're getting to the exceptions, the bright spots, what's already happening that we can expand on. And finally, the miracle question. If a miracle happened and you came to work tomorrow to find it was really easy to deliver patient and family-centered care, what's the first thing you'd notice? And this question helps us get at what do they believe is possible for baby steps? What do they believe is possible? These kinds of questions can be adapted for anything. Okay? It really just helps us get at that initial culture. Once we have this information, then we can start to go back, look at all the great wisdom and information that we have, and cut a key that fits that door. Okay? To get that traction, to get that implementation. And why does that matter? Simon Sinek on TED, I don't know if any of you have seen his talk on how great leaders inspire change, but you should watch it immediately after you leave here. It's really, really good. He's actually talks about how the biggest mistake we make in healthcare, and that is that we focus too much on the what and the how. We say, here's what we want you to do, and here's how we want you to do it. And we assume the why. We assume everybody knows it's a good idea to engage patients in the process. Okay? But what he talks about is that these three circles relate loosely to brain physiology. So the outer layers of the brain, your prefrontal cortex and all the new parts of the brain, are the parts that plan and create flowcharts and make documents and lists of things to do, your grocery lists, all of those things. And it's the part that speaks. It has language. Loves to plan. Loves to plan. It's conceptual. Loves to play with concepts. It's like a new technical device we've had in the last few million years that we're developing, okay? But the old brain, which is at the middle of the brain, is the part that actually governs behavior. So it's so old that there's literally billions of neural networks to the body and the muscles that actually make those choices. So the why, actually, when you get at the why, it helps motivate change. It actually makes motivating change possible. Okay? People will do what you, or at least consider doing, what you are asking when they believe what you believe. And you're listening to somebody talk and you're thinking, you know what? That just feels right. And the reason it's just a feeling is because that midbrain has no language. So you just get a felt sense. We call it a gut sense. And I know there's a lot more neural information coming up from the body than there is going down, so maybe it is a gut sense. I don't know. But we feel it that way. It's just like, oh, yeah, that just has a ring of truth to it. So focusing on the why is really important when you're working to implement change. And you can't do that until you know the story that exists now. You can't bring your information in a way that really focuses on that why. The other thing that it helps us do when we've got the current stories, it helps us make our ideas sticky. So this is the Heath brothers' work. Dan and Chip Heath, one teaches at Harvard, the other one at Brown, I think. And they've written this great book called Made to Stick. And again, if you don't have it, go right to Chapters immediately and get it, because it's fabulous. What they talk about is that in this day and age, if you really want an idea to stick, it better meet these 6 requirements. It better be simple, because we are all so overwhelmed with complicated ideas. It better be unexpected, because again, we're at the end of the information age, and people are sick of information. They're sick of it. It can be felt as an act of aggression to give people any more information right now. In fact, in the next DSM, they're talking about putting it in there as a mental issue. We're so anxious because everywhere we look, we have to sort through information all the time. It doesn't mean anything anymore. We have to make it meaningful. So it better be unexpected. Better be concrete, not abstract, which is what the new brain likes to do. It likes to make it really conceptual and abstract. It better be credible, so based in something real. It better have that emotional connection to the midbrain. And the way that you know you're doing all that is if it's story-based. Stories have all that. Stories are sticky. They're sticky, both in hearing them and in telling them. The other thing that knowing people's stories helps us do is it helps us follow the wisdom of IKEA, which I love. You can't ask tired people to change. It's just not nice. And we have a lot of really tired people in healthcare. They have been asked to change and change and change and change and change, and they're operating, like I said, many units at 110% capacity all the time. They're exhausted. They're exhausted from too much information. They're exhausted from the workload that they have. And to ask a tired, I don't know when the last time you tried to change anything about yourself is, but it's a lot of work. Your diet, your relationship with your husband or wife, your kids, takes a lot of effort, and it's really difficult to do if you're tired. So if you're going to ask people to change something, you have to find or generate the energy for that. IKEA rocks at this. You need a bookcase, so you'll drive all the way down there to the edge of town. You'll walk all the way through the whole thing because you can't get out until you do, right? Look at all the possibilities, and then you'll take home all the cardboard boxes, cut them open with the thing, and you have to cut them up, recycle them, then you have to screw everything together with that tiny little Allen key. And at the end of the whole day, you have a bookcase, which you could have just bought. Why? Why would we do that? We do it because we get to be co-designers in the process. It's more fun. It's more fun. And yet sometimes it's cheaper, but sometimes it's not. I know, I've dropped a lot of money at IKEA. And we all know the stuff doesn't last that great, right? So, but it's more fun. You go to IKEA as an event. Let's go to IKEA. We'll have one of those little hot dogs. Okay? All right? The end user becomes a co-designer in the process, and you can't do that well unless you know your end user well. So given those kinds of principles, and which is kind of what is exactly what we did in SHIP, it's just kind of bringing you a few other voices in terms of how it was done. We came up with a very simple plan for what to do in Alberta Health Services with patient engagement. We had our North Star, but it was like, how are we going to get there? 4 steps. Make it meaningful. Make the message meaningful. Why do we need to bring patients in to look at what we're doing? Why does it matter? Both from what's in it for me point of view, but also what's in it for all of us collectively. Then go in and empower action, actual action. Prove it works, and what I mean by works, I mean prove the connection between looking at what we're doing through the patient's eyes and quality outcomes. Reduce costs, reduce wait times, improve job satisfaction, improve safety. Prove it. And finally, tell the story. And then do it again, and then do it again. And then do it again. So repeat. So that every time we prove it and we go out and we tell the story again, it becomes more meaningful. So right now, we're about right in the middle of that process. Okay? So what's happened so far just by making it meaningful? I've hired a group of educators who are all great curriculum developers and who've worked with me to try to make this message really meaningful to staff. We've done hundreds of presentations. And at this point, I've gone from 2 years ago thinking, how the heck am I going to get anyone to care about this? Because they're all so stressed in healthcare. To, at this point, I just counted yesterday, we have over 250 projects on the books. Now, these are projects that we were invited to come in for. Okay? So it's not like we're going out and saying, hey, you should listen to this. They're calling us. Okay? My staff is more than doubled, and I could put 3 more people to work by Christmas, easily. Our workload is very high right now. We're getting 6 to 10 requests a week from operations to come in and help them figure out how to look at what they're doing through the patient's eyes. So making it meaningful really works. We always start by listening before we do a presentation. We start with those questions. Before we go in and do consultations, we listen first. What's important to you? What do you do here? What gets in your way? And then we make that information meaningful to them. The next thing that we're doing on our list is obviously scrutiny. So I have an MBA fellow that I've hired from Toronto who's coming in and he's helping us get these measurements between the relationship between the patient's perspective, improving the service, and quality outcomes. So that's our next step. So I go back to my grandfather and I think about this idea that you can learn anything you need to know from a tree. And as I said, the intersection between knowledge translation, engagement, making awesomeness happen, I really do think of a tree. When you put a tree or a tree seed into a field, the first thing it does is start listening. Listens for what's available, listens to the soil, listens to the sun, listens to what's around it, senses it, and uses that to strengthen its nature. And when we bring ideas into organizations and into groups, we need to think about it that way. Our ideas are only as good as the strength they draw from the stories and the environments that we put them in. So if we start by listening, we have a much better chance of growing our ideas into that tree of knowledge or into that successful experience. At least that's what I've found out. I love to end my presentation with this. Those of you who've seen my presentations have seen this slide before. There's so many problems we need to solve, and there's so much important work that needs to be done, whether it's in health or fixing our biosphere. There's so much scientific information that we need to get in the hands of the people and engage them in a way that strengthens those ideas and creates energy. Nobody's going to fly in here and do this for us from someplace else. We're the experts on this, and I think that I hope that people will consider joining a community of practice today and begin to help each other figure out really how do we make this possible. So, thank you.
Can you talk a bit about the importance of social status?
Social status. Now, why would you ask that?
You mentioned it in
Yeah. We have a tool on our website that we've developed. As I said, I had that eclectic background, so a big part of my training was acting. And I had a great teacher from the Royal Court Theatre in London who talked about status a lot. And it's a bigger topic than I can probably cover today, but certainly with physicians and caregivers, it's really important to understand social status and how you shift and change it with the way you use your body. So if a doctor has to deliver difficult news, much better if that doctor sits down to do that, so that their head is actually at your height or lower. It's a much better way to feel, for people to feel heard if when they're speaking to you, if you tilt your head slightly. So there's lots of skills that we can teach practitioners in the moment to help that experience with the when I tilt my head a little bit, it lowers my status. Okay, if I look right at you, it raises my status. Okay, so when we bring people into hospital, we take away all their social status indicators. We put them into those gowns, their butts hanging out. We poke them. We do all kinds of things to them. And when that happens, anxiety increases. And anxiety is the enemy of healing. And when we look at our complaints across the province, when we make people more anxious than they already were when they got there, it's a big problem, big problem. So everything that we can do to raise their social status back so that they feel like we see them as a person who owns a business or who's head of a family versus a number, is really, really important to do. So it's one of the things that we do teach practitioners to help with the patient experience, yeah. There's a lot more about that, though. It's a good question.